So we'll go ahead and call the meeting to order, and if you'll rise with me for the Pledge of Allegiance. I pledge allegiance
to
to the flag
of the
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, Dee, if you could call the roll.
Director Nicholson,
Present.
Director Yee,
Present.
Director Stewart,
Present.
Director Epen,
Present.
Director Wallace.
Present.
Very good. And Dee, if you could tell us who is in the room there with you.
In the room, we have Kimberly Hartz, Chris Henry, Ed Fayen, Larry Lavoisier, Paul Kozachenko, Noah Bell, and me, D'Antonio.
Great. Thank you very much. Well, good evening and welcome to the November 10th, 2021 regular meeting of the Washington Township Healthcare District Board of Directors. To continue to protect the health and safety of members of the public, the board, the district staff, and members of the public from the dangers posed by SARS-CoV-2 virus, the Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953 E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid-19.acgov.org. I now ask for a motion that the board make the finding required by section 54953 E3B2 of the Government Code that, quote, state or local officials continue to impose or recommend measures to promote social distancing.
Mr. President, I make the motion that the board make the findings required by section 54953 E3B2 of the Government Code that state or local officials continue to impose or recommend measures to promote social distancing.
Thank you. We have a motion. Do we have a second?
Second.
Second from Director Wallace. Dee, if we could have a roll call.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Wallace.
Aye.
Very good. The finding is affirmed unanimously. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. We'll now move to the communications segment of our agenda. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Dee, do we have any written communications?
No, we do not.
Okay, thank you. We'll now move to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Hearing none, does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar, items A and B?
In accordance with the district law, policies, and procedures, I move that the Board of Directors approve the consent calendar items A and B.
Thank you. We have a motion. Do we have a second?
I'll second.
Second from Director Yee. D, could we have a roll call vote on the consent calendar?
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Wallace.
Aye.
The consent calendar is approved unanimously. So now we have our presentation on the annual audit. And Kimberly, can you introduce our presenters?
We have Will Cobb and Philip Nowak and from PricewaterhouseCoopers that is going to present the annual audit for fiscal year 21. I'm actually going to have Chris Henry, since he played a very leading role in this audit, and I do want to thank him for the work that he's done with the audit and partnering with Will and Philip on this. But I'm going to turn it over to Chris to say a few words and also to introduce our two guests this evening.
Yeah, thank you. Can you hear us okay?
We can hear you fine.
Okay, great. Yeah, I just want to make a couple of acknowledgments before we dive into the audit results. You know, every year the audits seem to get more and more rigorous, and a lot of work goes into it really all year. So I do want to acknowledge Dave Tapia, our Director of Accounting, Erica Luna, our Assistant CFO, and in particular, Sandy Bemis, our Controller, who has put enormous hours and work into this audit, and the results of that work you'll see tonight. So thank you to those three. Now I'll introduce Will and Philip. Will Cobb is a partner in PwC's Health Industries Group based in San Francisco. He has 23 years of experience serving clients primarily in the healthcare, nonprofit, and governmental industries. Will received his undergraduate and graduate degrees from Auburn University, is a certified public accountant, and is a member of the American Institute of Certified Public Accountants and the Healthcare Financial Management Association. Will has significant technical accounting and financial reporting experience related to healthcare, governmental, and not-for-profit entities. He has extensive experience with bond offerings, affiliated foundation audits, and complex healthcare industry accounting and audit matters. With Will tonight is Philip Nowak. Philip is a director with PwC's Health Industries Group, and he is also based in San Francisco. He has over 12 years of experience serving governmental, healthcare, and nonprofit organizations. Philip graduated from the Haas School of Business at the University of California, Berkeley, and is a certified public public accountants licenses in California and is a member of the AICPA. Philip spent 3 years as PwC's review specialist in the Western United States for federal compliance under the OMB uniform guidance. In addition to providing accounting and auditing services to his clients, Philip has extensive experience with bond offerings, advises on complex accounting matters, and has developed and instructed trainings for both PricewaterhouseCoopers and the American Institute of Certified Public Accountants. And with that, I'll turn the program over to Will.
Thank you, Chris and Kimberly, and echo the comments. Certainly appreciate management's assistance in fulfilling all their responsibilities and satisfying our information requests and being responsive to our inquiries. That does not go unnoticed. So we will walk through the completion communications document, and please stop us if you have questions or comments as we move through this. And with that, Philip, I think we can proceed. Yeah, so just first start out with some highlights on the status of the audit for the district. The audit is substantially completed, pending the receipt of the management representation letter, which we get at the very end of the audit. We will anticipate issuing an unqualified or a clean opinion on the district's financial statements. One item of note that there was a lower collection rate of patient accounts receivable balances, which triggered additional audit procedures that were not initially contemplated in our plan. Those items have since been resolved, and we'll go into those in a little bit more detail later on. Independence and other required communications, we are able to affirm to you our independence working with the district and our ability to be your external auditors. On the audit findings standpoint, there were no uncorrected or corrected audit adjustments for the 2021 audit. And we are able to report to you that there were no material weaknesses identified in the course of performing our procedures. Risks and results. So each year, as part of our risk assessment process, we determine the areas of most significant risk. And for the 2021 audit, there were two significant risks identified. The first is the risk of management override of internal controls. This is a standard significant risk in all financial statement audits. We're essentially obligated under the auditing standards to identify this as a significant risk and incorporate that risk into our audit procedures. There were no significant findings as a result of our audit procedures in that area. And then the second significant risk area is a very common significant risk in the area of healthcare, which is essentially the valuation of accounts receivable at the end of the period. Given the nature of the provision of healthcare, the third-party payer situation versus the patients receiving the service, this is very common. There's estimation involved in evaluating the valuation of accounts receivable. At the conclusion of our procedures, there are no significant findings for that area as well. Just briefly, I mentioned this, the management override of controls. Here is a listing of some of the procedures that we perform and are incorporated in our audit plan, conducting inquiries with members of senior management and management, the accounting function about the risks of fraud, considering fraud risk factors present, considering the results of analytical procedures, evaluating management's programs and controls related to fraud. We incorporate an element of unpredictability into the audit, reviewing accounting estimates for any hints of bias, management bias, and we test journal entries for appropriateness. There were no significant findings as a result of those procedures. The other significant risk, as I mentioned, is the valuation of patient accounts receivable. And as I mentioned, the collection rate was lower this year when we trended accounts receivable versus previous years. And so typically the procedures in AR valuation is we evaluate subsequent cash collection. So the cash coming in July and August and into September, and evaluating how that cash comes in relative to that net value recorded on the balance sheet at period end. But due to changes in the composition and the aging of that accounts receivable, it was necessary to perform additional cash collections analysis with the remaining uncollected portion. And as a result of those additional procedures, we determined that management's recorded amount, which included a management adjustment, additional management adjustment, which was recorded post year end, the amount was determined to be reasonably stated. So we're able to conclude that the valuation estimate is appropriate for the amounts recorded in your 2021 financial statements. One other area, not an area of significant risk, but it is a significant accounting estimate, is with respect to your actuarially determined pension and other post-employment medical benefit obligations. This is an area where the district utilizes the services of a third-party actuary to perform the valuation. We in turn utilize actuarial specialists to evaluate the assumptions, the selections of the assumptions within that actuary report, and listed here significant assumptions reported by the district's actuary. And the conclusion of those procedures, we determined that the actuarial estimates for pension and OPEB were reasonably stated. At this point, I will turn it over to Philip to discuss the adoption of a new accounting standard.
Thank you, Will. This year, GASB 84, which is related to fiduciary activities, was a piece of guidance that the district had to implement. The Governmental Accounting Standards Board, GASB, they regularly issue new pronouncements in terms of how financial statements will have to be updated or how certain areas will have to be treated differently. And this is one that this year actually caused somewhat of a structural change in the district's financial statements, where when you're looking at the financial statements, you'll see the typical statement of net position, the statement of changes in net position, the statement of cash flows. And immediately after that, this year, what you'll see is two new statements added. Essentially, it's a balance sheet and income statement related to fiduciary funds that are now being presented within the district's financial statements. And for the district, what this relates to is it relates to the assets being held for the pension and OPEB plans of the district. And so you'll see those, as I mentioned, immediately after the core financial statements of the district. And so it is something different this year. Something unique about those statements as well is that you'll see that they have a 12/31 year end as opposed to a June 30th year end. This is something that is in line and able to be done under GASB, and this is done because those underlying plans do have December 31st year ends, and so those fiduciary fund statements are aligning with what those plan statements, with what those plans have for their individual year ends. The district did consider some other benefit plans that were out there, and some other employee post-retirement plans, and ultimately concluded, and we agreed that what is presented within these fiduciary statements is appropriate under the guidance of what should be presented here. Something else that's going to be new for the district this coming year is because of the funds received from the federal government under the CARES Act, primarily related to the Provider Relief Fund program, the district is going to need an audit in accordance with the OMB uniform guidance. This sometimes goes by another name, sometimes it's referred to as a single audit. Formerly, it used to be referred to as an A133 audit. These are ultimately a compliance audit required by the federal government for these funds. And so this is something that we will be performing for the district coming up within this year, related to CARES Act funds that have already been received. Few other required communications that are included here, just a couple that I'll highlight. Will mentioned earlier that from an independence perspective that we can affirm that we are independent. Only repeat that because it's something that we consider to be very important as it relates to our relationship with the district. Also, something else I'd like to highlight is, as part of our procedures, we did not identify any fraud, illegal acts, or any non-compliance with any laws or regulations. And so, so I will pause there and just see if there are any questions from anyone. Okay. Will, anything else on your mind before we conclude our presentation?
No, I think that's it. That completes the required communications, and we would certainly turn it over to the audience for any questions or comments. Happy to respond to any questions that you may have.
Great. Thank you very much, Philip. And Will, any questions from the board members? Any comments? I guess the thing I have to say, I'm very pleased to hear of a clean audit for this year. It's been a challenging year, and we appreciate all the hard work of PwC and going through all of this data to provide us with this audit report. The audit report is essential to the community, the employees, and especially the bondholders in having the confidence that our financial reports actually represent the current status of our institution. So we thank you for all your hard work. And we also thank the administrative team, Kimberly, Chris, Sandy, as well as the whole finance team for all their hard work in bringing this about. So any other comments or questions? If not, I think we need to approve the audit report. And if I could have a motion for approval.
Mr. President, in accordance with the district law, policies, and procedures, I move that the board approve the report to the Board of Directors fiscal year 2021 audit results.
Great. We have a motion from Dr. Epen. Do we have a second?
Second.
Okay, second from Director Wallace. Dee, if we could have a roll call vote.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Epen,
Aye.
Director Wallace.
Aye.
Thank you. The annual audit report is adopted unanimously. Thank you, Will, and thank you, Philip. You take care and have a great week.
Thank you. You as
Thank
well.
you. Bye-bye.
Okay, we'll now move on to our medical staff report from Dr. Hyder, who I believe is with us. There he is.
Yeah, good evening to all. Thank you so much. The November 2021 grand total staff is 569 with active staff is 346, administrative 1, allied health 31, ambulatory 91, consulting is 8, courtesy is 24, leave of absence is 6, provisional active 47, and provisional AHP 12, provisional courtesy 2, and relinquishment 1. So the grand total is 369. This is the total staff up to date.
Great. Thank you, Dr. Hyder. How is the vaccination progressing
It is
with
progressing
the
the
booster shots
fi-
for the physicians?
Yeah, it is going very well. They are making appointments, and whoever I asked, they have taken already. Now we are giving it to the children also for 5, and mostly in the morning time with appointment, Alameda County children. So it's going very well, very smooth. Excellent.
Very good. Well, thank you very much, Dr. Hyder, for your
Thank you so
report.
much. Thank
Keep
you
up
so
the
much.
good work.
Thank you.
Okay, our next report is from Debbie Fury, the Service League. Good evening, Debbie.
So Dr. Nicholson, I just want to jump in. Unfortunately, she was not feeling well. So I have Angus Cochran is actually going to give her report this evening. So I just.
Okay, I saw Debbie earlier, but.
She was here earlier, yes, but she isn't feeling well. Yep. All right, Angus.
Good evening, everyone. I'm definitely not Debbie Ferry, the president of the Service League, but I'm happy to give her report on her behalf. The Service League had a busy month in October. There were 114 volunteers contributing 1,585 hours in their assignments. Our spiritual care volunteers were especially busy. They spent 57 hours ministering to patients in October as well. We've been able to welcome back a few high school volunteers in the gift shop. And so the Service League is planning on adding some Saturday hours with their assistance. In general, I think, a lot of activities are coming back to some of the levels that we had before. the pandemic. The WOOF Canine Therapy Program has now expanded from just a couple of areas to now having our canine volunteers visiting patients throughout the hospital. And then finally, Debbie, I know if she were here, she would be over the moon to tell you that the Masquerade $5 jewelry sale will be returning on site in Anderson Auditorium in Washington West from November the 29th through December the 2nd. Volunteer services and the Service League are working very closely with infection prevention to make sure that it's a safe shopping environment. Masks will be required, and we're putting capacity limits on the number of people who can visit at any given time. So it will be a well-managed and safe shopping experience. So as Debbie put in her report, shop early and shop often. That's the report. And if there are any questions for Debbie, I'm happy to pass them along to her.
Well, thank you very much, Angus. You know, I'm really glad to hear that we're having the $5 Masquerade sale in person, on site. Bring your credit cards, buy lots. It's great for the holidays. So wonderful to hear, and it's really wonderful to see the volunteers, especially the high school volunteers, back with us. So give Debbie our best wishes. Hope she feels better, and we look forward to seeing her next month.
Thank you. I'll pass that along. Thank you, President.
Thank you. Okay, we'll now move on to our quality report, which is going to be given by Mary Bowron. It's going to be the quality dashboard for quarter ending September 30th, 2021.
Great, thank you, Dr. Nicholson. Yeah, I think overall this is a great quarterly report. Out of all the metrics we'll be presenting tonight, we only have one that is more than expected. And so I just want to start off by going into the infection prevention indicators. Our first one is looking at hospital-acquired MRSA, which is in the blood. This is for patients who have MRSA, a bacterial infection that's very hard to treat with antibiotics, identified in their blood after the third day that they've been admitted to the hospital. I'm happy to report that we have had 0 this last quarter, and that is actually less than expected for a hospital of our size and type. And then moving into the catheter-associated urinary tract infections. This probably still continues to be one of our biggest challenge areas in infection control. We did have 3 catheter-associated urinary tract infections this last quarter, which is about 2 more than the CDC would expect for a hospital of our size and type. It is a 1 up from what we had last quarter, as you can see, but we still are overall less than from the initial rise that we saw earlier this year. And so there's a couple things we're doing. We have a dedicated team that looks at these cases and tries to find a root cause of the associated infection. That's one thing, is looking at the data analysis. And what we do is we use that data information to determine what we can do to make improvements. And most of this is around process improvement. We start off by every single shift right now, the nurses are actually re-reviewing whether or not the patient meets medical necessity for the urinary catheter. That's really important. They're great to have when they're needed, and the moment they're no longer needed, they should be removed. And at Washington, the nurses have it within their scope and protocol to remove the catheter if the patient doesn't meet for medical necessity. We've been really focusing on that in the last couple of months, and our catheter days have come down. And I think that that's one of the things that we're continuing to see will hopefully lead to less CAUTIs. It's also important to monitor the care and maintenance when the catheter is in place. So we're doing auditing around that and education with infection control. The important thing is that the whole team is working together. Infection control is working with nursing. The medical staff have been very active in trying to help us bring down this outcome to 0. And in the month of October and so far in November, we have 0. So I'm hoping that since we're this far through the quarter that, we'll continue to see hopefully get under the benchmark next quarter. Central line associated bloodstream infections, very similar approach that we take with preventing CLABSIs as we do with CAUTIs, because again, this is a device that's similar to an IV, except it extends much further into the vein and terminates close to the heart. So it's an invasive device that's great for giving IV fluids, medications, etc., but one that we really want to monitor and take care of carefully when it's in place in the patient and remove as soon as the patient doesn't need it. And this last quarter, we had a great outcome of 0 CLABSIs, which is ultimately what we want. The CDC predicted that we would have closer to 2 infections. We don't have a standardized infection ratio, but it looks like we're supposed to have closer to 2. So we're definitely under the benchmark for that. And we want to really make efforts on sustaining this. For the month of October and so far in November, we've sustained it at 0. And again, it's the same team working together to make sure that these lines are well taken care of in place and then removed when they are no longer needed. Our surgical site infection data is specifically on this slide related to our colon surgeries, which are high risk by the nature of the organ that they're doing the surgical procedure on. And we have, again, seen a good outcome here with having 0 SSIs related to colon surgery. And we did have this uptake further earlier on in the year. But again, like I said, this has come down. All of the cases that we do identify are really taken seriously. They go through the surgery committee, they're peer reviewed by physicians. We're actually now also working very closely with the OR team. Having infection preventionists are free to go into the OR and watch procedures and sort of give education and really communicate with the team there to looking at how we clean our rooms and how we do whatever efforts we need to make to reduce the risk for SSIs. And I think we're seeing some good outcomes from that. Surgical site infection also with our abdominal surgeries, in this case, specifically to a hysterectomy. And we have seen 0 of these, and this is really a sustained good outcome for a significant period of time, over a year. We survey these very closely. It's required by CMS, just like the colon surgeries are also required by CMS. Again, same process. If we were to identify one, it would go through peer review process. And we haven't really had an issue with that at all. Again, another high risk procedure for SSIs, doing very well. Our C. diff is really sustained well from some of the issues that we were dealing with over a year ago when we were seeing an above average number of cases. We have now, this time for this first quarter ever, seen 0 in a quarter. And the CDC expected us to have 10. So that's a very significant statement that with the risk factors in place, we're predicted to have 10 and we have 0. We've continued to see this decline. As you can see on the blue lines, went from 10 to 8 to 3 to 2 and now to 0. I think it's a great reflection of physician practice, being very careful about how we prescribe antibiotics that put patients at risk factors for getting C. diff. We're also looking very carefully at our testing procedures and with patients to make sure that we test patients appropriately to see if they have C. diff. And this is just a combination of infection prevention's task forces working with nursing and medical staff. And I'm continuing to hope that we see this sustain also moving forward. Hand hygiene is an indicator that we will always have to be working on, continually coming up with new ideas for how to keep our staff in compliance with washing their hands whenever is required. And currently we are at 89%, which is actually above the World Health Organization goal of 70% and just a little bit below Joint Commission, which is asking for 90% compliance. And I always think it's interesting that the WHO and Joint Commission have, benchmarks around 70 to 90%. And it's because it's such a challenging thing to get good behavioral compliance on. And I'm happy, we're happy that we have it at 89%. Really, our ultimate goal is to have it at 100% because it's never acceptable to not wash your hands when indicated. But we recognize the things that go on in healthcare settings that are very complex. And so one of the things we've been doing is working with patient safety closely to identify more people working on different units throughout the hospital, working to help us monitor hand hygiene throughout the hospital so that we have a large number of things and interactions that we're looking at, but more importantly, it's so that they can have those discussions with the frontline staff about what would make it easier. You know, do we have our Perel dispensers wherever we need them to have good access to washing your hands easily, watching to see, are people getting interrupted as they're going and leaving a room and going to wash their hands, etc. So we're taking that data and looking at it and doing additional training with new staff. We have a lot of active participation and throughout the hospital. And that's one of the groups that we want to really kind of work to bring together more moving forward and do some more training to see if we can get this up to closer to 100%. Our nursing sensitive indicators specifically start off with injury falls. So again, these are patients that have what is defined as an unplanned descent to the floor. So a fall. And for this, our outcomes are continuing to do well. This is heading in a downward trend. We were under the benchmark of 0.60. We were at 0.3. And just to explain that a little bit better, this is in a rate format. So per every 1,000 patient days, we had 0.33, which is the rate, which is far less than the 0.6. It is a reflection of 5 falls, and even though the patient days were significant, 5 falls is still 5 falls. And so because of that, the falls committee looks at each fall, and 3 out of these 5 were related to getting up to go to the bathroom. That seems to be a trend. It's a trend nationally, and we're seeing that here also, that it's when patients try to get up to go to the bathroom on their own without calling. So the nursing staff is doing a lot of good initiatives around frequent rounding, making sure that when you get patients settled for the night, you assist them to the bathroom prior. These are some of the root causes that we're looking at to make sure, because again, under the benchmark for the second quarter, but our goal is ultimately we'd like to have 0 of these falls. Hospital-acquired pressure ulcers is at 0. We did not have any for this quarter. That's also really been a sustained effort, staying under the benchmark continually for well over a year. And this is another area where it's really a reflection of making sure that patients are on the right beds with the right mattress, are moved when they can't move themselves, that we're taking care of their skin while they're here, following up with the right nutrition. And I think that we've reflected all of those standards in this outcome being at 0. Our readmission rates, this is something that has also been a challenge for us over the last couple of years. And we actually in this quarter for all of the readmission metrics are under the benchmark, starting off with patients who have a heart attack and then are readmitted to the hospital within 30 days. Our rate is 14.3, which is lower than the CMS national benchmark of 15.8%. This is a reflection of 3 unplanned readmissions. And all these patients actually were, even though they were admitted related to their initial diagnosis, again, was the AMI, the heart attack, but when they were readmitted, these were actually not related to cardiovascular issues with all 3 of these patients. And all of these cases where patients come back are reviewed by the readmissions team and committee to look for, again, root causes. Why do these patients come back? And this will apply with all of the disease states that I'm going to present on the next few slides, but I just want to summarize really quickly, what is the standard that we do to prevent readmissions in patients? The committee looks at each patient that comes back. We look at why they came back, if they needed to be admitted to the hospital, because if they can be managed on the outpatient area, it's better for the patient not to have them go through an acute care unless they really need to. All of the patients actually have met for acute care in all of the slides that we'll be presenting. But there's the issues around making sure that they're seeing their primary care provider after they leave. We've got some patients here that actually didn't, of the 3, didn't have an appointment or didn't make it to the appointment when it was made. So we're trying to do better with intervening with follow-up phone calls and calling on the patients, reminding them, helping them get transportation if they need it, or if they start sort of forgetting their medication directions or don't have a way to access their medications. These follow-up phone calls are put into place to make sure that we can assist them with that before they start to decline to the point where they need to come back to the hospital. So we're following those standards of care. Moving on to the next slide. Pneumonia has been a real challenge for us. This is, of course, the first quarter where we've been under the benchmark. It's a reflection of 5 patients that came back, giving us a readmission rate of only 9.4, which is lower than CMS's benchmark of 16.7. Again, using all the same standard interventions that I just mentioned to reduce pneumonia readmissions. This patient population has been more difficult for us to manage. There are a lot of different reasons that we've looked at in the past quarters, but for these particular 5 patients, there was a great deal of chronic illness. They were all over the age of 75. We also have some social determinants in this group of patients that sort of impacted their care outside of the hospital. And we always support those patients when they come back into the ED and they need to be admitted to have a safe care plan, then we admit them, always lean on the side of that for patient safety reasons. And there were a couple of complex cases this quarter that required that. Heart failure also is another challenging disease state for us, but this is our 2nd quarter in a row where we've been under the benchmark. We did have 7 patients over the quarter that were readmitted, giving us a readmission rate of 12.5%. It is significantly lower than the CMS benchmark of 21.9%. Same thing with these patients. They were chronically ill, of course, because they're in a state of having heart failure. But with these patients, it looked more like around medication management. These patients actually had follow-up appointments made. They did also get follow-up phone calls. It was just that they had other issues that led to them having to be readmitted. And but again, we're still follow all the same standards with this group of patients that I mentioned prior. And next slide.
Daddy.
Yeah, baby.
COPD is very as another challenging area of chronically ill patients.
Right now, I will.
2 patients that were readmitted this quarter that gave us a rate of 9.1%, which is lower than our CMS national benchmark of 19.7%. We've really been working closely with the RT team to make sure that these patients, they have actually different interventions than the other groups I've mentioned. We make sure that they have specific education to use of their oxygen, and we review all of these patients benefit from pulmonary rehab. So this group is a little bit different on how we manage it. And again, the reflection of the RT team is really good in this.
No, I guess.
And then moving on to almost to my last.
Yeah, it seems like somebody has, we're picking up noise from a child. Does somebody have their mute?
I think it's
like an
alter your phone. It's a cute sound. It's
I don't see.
Yeah, if everyone can mute, that would be.
There he goes. Okay, he's on mute. Okay. So yeah, so the only thing I was specifically saying about the COPD that it is managed a little bit differently in maintaining education around how patients use their oxygen and making sure they get to pulmonary rehab if they qualify. So this population is a little bit different in how we manage them. But again, I think the RT team working with pulmonologists have had some good outcomes on this in the last quarter. And next slide. The last 2 are a reflection of surgical patient populations. This patient population is also required by CMS, which is for patients who have a coronary artery bypass graft, otherwise known as a CABG. They're high risk for readmissions. And the good news is that we have now gone 5 quarters without having any of these patients readmitted. This is a great reflection of care that is managed well, all the way from the OR to the intensivist team, to the nursing team. All the ancillary staff who work with these patients are really making sure that they're stable, ready to be discharged when they're discharged, and they have a good care plan. And they've had a lot of follow-up afterwards. I think there's a lot of good standards being met here, and we haven't really had any issues around them being readmitted for a while. And the next group, of course, is related to our elective primary total hip arthroplasty, so our total hips basically, and our total knees. We have a large volume of these patients, so we're always watching, even beyond the fact that this is a CMS requirement. This is a service line that we look at very closely, obviously, because it has such a large volume. And you can see that for the 3rd quarter in a row, we have had 0 readmissions in this patient population. Again, this is a reflection of good standard practice happening from the OR to post-op and to the discharge team. A lot of these patients also are eligible to have this procedure outpatient. That is not reflected in here. The 25 cases that we're looking at are actually inpatients, which means that they're a little bit higher risk for being readmitted. And so of the 25 patients we had to manage, none of them came back. Thank you. Any questions?
Any questions for Mary? No, it's good to hear, Mary. It sounds like you have some young fans who are paying a lot of attention to our quality dashboard. That's good to hear.
That's not a bad sound in the background at all.
Yeah, that was fun. But to be honest, a very nice report. And what was most spectacular was the results on C. diff. As we've all known, we've struggled with C. diff for many years, for a long time, and worked hard on that in many ways. So to see 0 cases, I mean, that's a benchmark which will be hard put to continue, but it was great to see 0 cases this past quarter. And it really reflects the hard work of so many different facets of the institution to bring all the thoughts and resources to bear on reducing the risk posed by C. diff infections to our hospitalized population. So that's really hats off to the whole organization for bringing that about. It's actually an astounding result. If we had champagne, I would open it up today. The other thing is it's good to see the nurse-driven protocols for getting those urinary catheters out. I know that is going to be one of the elements to help reducing our risk of urinary catheter based infections. So thank you very much for your report, and it sounds like you have a fan club.
Yeah. Thank you.
All right, you take care. Okay, we'll move on to our finance report. Chris Henry.
Okay, thank you, Dr. Nicholson. Tonight, we will be looking at Washington Hospital's operational and financial results for September. And jumping into our acute inpatient statistics, our inpatient average daily census for the month was 18.6% higher than the budget at 154.9. Our combined average daily census, which includes our observation patients, which are not considered inpatients but are still occupying a bed, that average daily census combined was 22.3% higher than budget at 166.3. We saw 804 admissions in the month, 55 higher than the budget. Patient days were 18.6% higher than budget at 4,648. Our outpatient observation equivalent days continued to be higher than budget. We'd expected 161, but we ended up with 342. Average length of stay for the month was 0.55 higher than budget at 5.78. Looking at utilization, case mix index for the month was lower than budget at 1.608. We had 141 deliveries in September. I haven't seen that number in quite some time. That was a variance of 21.6% higher than the budget of 116. Surgical cases for the month came in 18.2% higher than budget at 384. Cath lab cases were 19% higher than budget at 219. Our outpatient visits for the month were at 8,102. That's 8.4% higher than budget. And our emergency visits came in 19.9% higher than budget at 4,401. So a lot of activity going on in the hospital in September. Looking at the details of surgical cases and cath lab cases in the operating room, really all of our major categories of surgical cases higher than budget, with the exception of our neurosurgical cases, which came in 8 below budget in the month. Likewise, cath lab cases, again, in all of our major categories higher than budget. Cardiac cases in the cath lab were slightly lower at 83. That was 2 lower than the budget, but still very strong performance in both the OR and the cath lab. Looking at productivity, our productive FTEs for the month came in 120.8 higher than budget at 1,333.4. That's about 10%. Non-productive FTEs came in pretty close to budget at 195.7. So our total FTEs for the month of 1,529.1, about 8.8% higher than the budget of 1,405.7. Our full-time equivalents per adjusted occupied bed was favorable for the month by 0.92 at 6.01. So productivity was looking pretty good with all that activity going on. Moving into the financials. Total patient revenue came in almost 20% higher than budget at $195,338,000. Our contractuals for the month came in just slightly below budget. We had some offsets going on there. If you recall from Kimberly's report last month, the mix in our government payer categories had shifted heavily to Medi-Cal in September. So that put a heavier load on our contractual allowances for the month, coming in about 21.1% higher than budget against that 19.8% of higher revenue. We made that up, however, on our provision for bad debt and charity with we had a pretty low private pay in the mix for the month that came in actually lower than budgeted, 1.1 million. So again, total deductions from our revenue came in really close to budget with those offsets going on. So we ended the month with net operating revenue that ended up 19.7% or $7.4 million higher than budget at basically $45 million. Operating expenses for the month were 7.5% higher than budget, about 2.9 million higher at $41,351,000. Major drivers here were, of course, our salaries and wages were higher. With our higher FTEs, they were $1.9 million higher than budget, about 11%. Did have some overtime in that number. Supplies were about $1 million higher in the month, largely driven by prosthesis, pharmacy, surgical supplies. Gloves are still really pricey out there on the market, and we used a lot more of them with the high level of activity going on. And our reagents were higher than budget. Pro fees and purchase services were about $247,000 higher than budget, largely driven by the SNF beds that we're utilizing to help get patients out of the hospital and into a more appropriate setting of care. And we had some architect fees hit in there in the month. And then those things were offset by our insurance, utilities, and other categories that was below budget by $214,000. Again, largely driven by electricity. We expected higher rates in electricity in the budget this year that just haven't materialized yet. Marketing and software maintenance were both below budget, largely due to timing. we had lower equipment leases in the month. So overall, ended up with a very good result on our operating bottom line of 3.652 million, about 4.5 million more than we had expected in the budget. Non-operating income for the month showed a loss of $739,000. We did have an unrealized loss on our investments during the month of $633,000. And again, our rental income is challenged with the amount of available space in Fremont Office Center and in Washington West in the shops. We have been signing leases. We've signed 2 leases here recently and have a third that I expect to see something on anytime in Fremont Office Center. And we should start to see cash flow on those. We're right now in the process of getting TIs together and getting the spaces ready for the tenants to move in, but we should start seeing cash flow start to materialize again after the first of the year. So we did end up the month with a pretty good bottom line of 2.9 million, about 3.7 million higher than the budgeted loss of $771,000. And again, this was from the GASB perspective, Governmental Accounting Standards Board perspective, which was used for the audited financials that you heard about earlier today. Taking a quick look at the Financial Accounting Standards Board format, this includes adjustments that financial markets might make when they're looking at our financials. The first thing we do is we move the interest expense that you see in the GASB statements down in non-operating out. And the first thing we do is we reclassify our revenue bond interest. For this month, it was $574,000 up into operating expenses, which is where FASB organizations recognize that. And we end up with operating expenses from a FASB perspective of 41.9 million and an operating bottom line of almost 3.1 million from a FASB perspective. Then the next thing we do is we eliminate the remaining GO interest of 1.2 million and the related tax revenue that we receive for the debt service on those GO bonds of a little over 1.4 million. And we remove that unrealized loss on investments. FASB doesn't recognize any of those. And we end up with actually a non-operating income for the month from a FASB perspective of 182,000 and a total bottom line of 3.260 million. Quick jump into EBITDA, earnings before interest, taxes, depreciation, and amortization. This is an estimate of what our operations are providing in income to support the debt service on our bonds, as well as capital spending and other program development. We look at our expenses before depreciation. Depreciation is a non-cash transaction, so we pull that out, and we end up with EBITDA of almost $7.6 million, which is the strongest number we've seen in quite a while. We then look at our non-operating income, excluding the interest expense, and we end up with another 990,000. So combined, Washington hospitals operating and non-operating activities generated about $8.6 million, again, for debt service, capital spending, and other programs. So are there any questions on the results of September?
Any questions or comments? Other than it's a strong month. Thank you very much, Chris. Let's go to operations, Kimberly.
All right, moving on to operations, and the October wasn't as busy as September, but still busy. So if we look at our gross revenue, 188.3 million for October was above the budget by 18.2 million or 10.7%, and above October of 2020 by 14.6 million or 8.4%. Looking at inpatient gross revenue of 109.4 million was below the budget by 1.3 million or 1.1%. And outpatient gross revenue of 78.9 million was above budget by 19.5 million or 32.9%. In October, we had 18 COVID-19 discharges, representing about 2% of our total discharges. I think this is probably one of the lowest numbers of COVID discharges that we've seen pretty much since the onset of the pandemic. Moving on to our key census statistics, our average length of stay of 5.24 was above the budget of 5.16 by 0.08 or 1.6%. Our outpatient observation days were 138 or 72.3% above budget at 329 days. And were 136 or 70.5% above October of 2020. Our inpatient average daily census of 142 was above the budget of 142 was above the budget of 132.1 by 9.9 or 7.5%. And then by looking at the combined average daily census of 152.7 was above the budget of 138.2 by 14.5 or 10.5%. Looking at the average length of stay for the 18 COVID-19 patients that were discharged in the month, on average it was 10.4 days. In October, there were 12 discharges that with lengths of stay that were greater than 30 days. They range from 31 to 65 days. And if we excluded these long lengths of stay, our average length of stay would be about 4.7. Fortunately, we still have in-house, we have 7 patients with lengths of stay over 30 days. And so we're continuing to look at appropriate placements when they are ready for discharge. Moving on to our admissions. Admissions were below budget by 12 or 1.5%. We had lower admissions for the month were impacted by the increase in the observation days that we saw, and also which resulted in fewer admissions, probably between 26 to 46. We're also continuing to see, as I've mentioned in the past, the shift in the joint cases from inpatient to outpatient, which is higher than we had budgeted. Admissions for the month were 50 or 6.8% above October of 2020. Looking at our patient day trends, as mentioned, admissions were below budget by 1.5%, but our average length of stay was higher than budget by 1.6%. This resulted in patient days of 4,403, and this was above the budget by 7.5% or 309 days. Patient days for the month were 268 or 6.5% above October of 2020. Our surgical volume, total surgeries in October of 362 were above budget by 38 or 11.7%. Surgeries were 19 or 5% below October of 2020. Inpatient surgeries were 37 or 22.6% below budget at 127, and 48 or 27.4% below October of 2020. Lastly, outpatient surgeries were 75 or 46.9% above the budget at 235, and 29 or 14.1% above October of 2020. Again, this really what we've seen here in the month of October, only 5% of the total joint replacement cases were inpatient, and we had budgeted approximately 35% to be inpatients. So really seeing that shift. Looking at the surgical activity broken down, joint replacement surgical cases were above budget by 42 or 32.3%, and were 14 or 8.9% above October of 2020. Neurosurgical cases were below budget by 5 or 18.5%, and were 6 or 21.4% below October of 2020. Cardiac surgical cases were above budget by 6 or 60%, and were 3 or 23.1% above October of 2020. All other surgical cases combined were below budget by 5 or 3.2%, and were 30 or 16.5% below October of 2020. I know we did have a few of our surgeons that were out for some time during this month. So that did impact our other surgeries. Looking at our cath lab trend, cath lab cases for October of 219 were 16 or 7.9% above budget, and 23 or 11.7% above October of 2020. Cath lab inpatient cases for October of 119 were 14 or 13.3% above budget, and 26 or 28% above October of 2020. Then lastly, outpatient cath lab cases for October of 100 were 2 or 2% above budget, but 3 or 2.9% below October of 2020. You can see the cath lab activity broken down. Cardiac cases were below budget by 9 or 9.8%. Non-vascular interventional radiology cases were above budget by 23 or 41.1%. Peripheral vascular cases were right on budget and in terms of at 50. And then neurointerventional radiology cases were above budget by 2 or 40%. So overall, pretty strong month again in the cath lab. Deliveries for October were 135, which were above the budget by 19 or 16.4%. So still, I think last month we were about at 141, so still pretty high in terms of deliveries, and they were 20 or 17.4% above October of 2020. Looking at our non-emergency room outpatient trend, outpatient visits of 8,014 were above the budget by 121 visits or 1.5%. Looking at the breakdown, our cardiac rehab visits were above budget by 124 or 23.6%. Our EKG visits were above budget by 127 or 57.7%. However, our lab visits were below budget by 68 or 2.2%. And our diabetes education visits were below budget by 62 or 22.3%. Looking at our emergency room visit trends, emergency room visits of 4,209 were above the budget by 442 or 11.7%. And we're above the same period of last year by 679 or 19.2%. And as mentioned, overall, our emergency room visits are pretty much aligned with where they were during pre-COVID times at this point. Going into gross revenue, deliveries were above budget by 19 or 16.4%, and there were higher charges per case, driving our birthing center revenue up by 793,000 or 26.9%. Our cath lab cases were above budget by 16 or 7.9%, driving cath lab revenue up by 997,000 or 8.1%. Emergency visits were above budget by 442 or 11.7%, and the level mix was higher, driving emergency room revenue up by 1.4 million or 13.8%. Patient days were above budget by 309, 7.5%, and we had higher utilization of ICU beds, which helped to drive the revenue higher than budget by 3.2 million or 9.8%. Total surgeries were higher than budget by 38, 11.7%, and there were more joint cases driving surgical services revenue up by 5.3 million or 16.7%. Lastly, outpatient activity drove ancillary services revenue above budget by 6.6 million or 8.2%. All right, moving on to our payer mix in terms of appears to have a more favorable payer mix this month. Government sponsored patient revenue made up 70.4% of total gross revenue. This is lower than the budget by 2% and lower than prior year by 2.7%. HMO was 2.8% of gross revenue, which is slightly above the budget of 2.7% and higher than the prior year percentage of 2% of gross revenue. Our PPO was 25.4% of gross revenue, which is above the budget of 22.9% and higher than the prior year percentage by 23.3% of gross revenue. Lastly, our private pay was 1.4% of gross revenue, which is below the budget of 2% and lower than prior year percentage of 1.6% of gross revenue. Looking at our productivity indicators, again, productive FTEs were above budget by 98.3 or 8% at 1,331. Our non-productive FTEs were above budget by 1.2 or 0.8% at 157.3. Our total FTEs of 1,488.3 were above budget by 99.5 at 7.2%. But looking at our productive FTE per AOB was at 5.45, which was lower than the budget of 6.08 or 10.4%, and lower than the prior year at 6.14. Also, at our total FTEs per adjusted occupied bed of 6.09 was lower than the budget of 6.85 or 11.1%, and lower than the prior year at 6.82. So overall, continue to look at the flexing given the volume and where we stand. Looking at our preliminary outpatient statistics, the Whitman Clinic visits were lower than budget in October by 1,147 or 6.1% at 17,528. Variance was mainly driven by cardiology, internal medicine, and OBGYN, and having physicians have some time off in those areas. In terms of DevCo, outpatient visits of 2,202 were below budget by 52 or 2.3% for the month of October. Looking at the breakdown, the main driver of this was the Washington Outpatient Rehab Center, which was down 155 visits, and that's basically due to having open physical therapy positions and that we're continuing to recruit, which is they're difficult to recruit for outpatient physical therapists. As you can see, Washington Radiation Oncology Center was above budget by 47. Outpatient Surgery Center was above budget by 56, and Ohlone College Student College Health Center was pretty much right on budget, and they just recently opened up now. Looking at our key financial statistics, our days cash on hand for October ended at 163 days, an increase of 2 days from last month, mainly driven by higher collections in the month. Our days of gross revenue and accounts receivable were 67, which represents a decrease of 1 day compared to the prior month. And for charity care, we did see a bump up in charity care. There were $762,722 in charity care applications pending or approved in October. And lastly, this is the quarterly summary for activity of the homeless patients. We can see for the fiscal year to date, September, there were 556 patient encounters, representing 361 homeless patients, of which 78 had more than one encounter during that period. The estimated total unreimbursed cost for fiscal year to date was about $2.5 million. And that is my report for October.
Great, thank you very much, Kimberly. Any questions or comments for Kimberly regarding October? Okay, it's nice to see those strong productivity indicators, Kimberly. That's great work on doing the appropriate flexing.
Yeah, staff has been working hard in that area.
I know that's a lot of work to make that happen, a lot of moving pieces. So that's very good for the organization. So I presume you've got some announcements.
I do have some announcements, and I'd like to start with the Employee of the Month for November. And that's Becky Stang has been a nurse in our birthing center for more than 30 years. From the time she was 6 years old and witnessed her firefighter father perform CPR to help save the life of a neighbor, Becky knew she wanted to be in a profession that would help people. She eventually found her way to the place where she was born, Washington Hospital. As Becky says, there's no greater joy than helping to bring a new life into the world. Becky's empathy makes her an exceptional nurse and also brings deep sadness when a baby is not viable. Fetal demise is unfortunately also part of the profession of a labor and delivery nurse. Over the years, Becky and her coworkers have created memory boxes for the parents of these babies, and recently she has become involved with a project to help with the arrangements and costs associated with these deaths. Working nights, Becky feels that she and her coworkers have a special bond. When you work nights, she says, you have to rely on your team. We have a very supportive and compassionate environment. The Director of Maternal and Child Health, Joanne Mantanan, describes Becky as someone who partners with a nurse management team to streamline workflows and always assist her colleagues. In addition to working at Washington Hospital, Becky has been a wife for more than 30 years, a mother to 3 children, a grandmother to 2 with a third on the way, and an active member of the Union City Lions Club, where community service for the blind and hearing impaired is the priority. She has also traveled to Guatemala on medical missions. Becky is an outstanding asset to the Birthing Center, and we congratulate her efforts and recognize her as the Employee of the Month for November. All right, and then I just want to do a few other announcements. In terms of the Washington Township Medical Foundation continues to operate our community vaccination clinic. And we are now scheduling people for vaccination 5 years of age and older. As of Monday, November 8th, a total of 73,412 COVID vaccine doses have been administered to community members at the clinic. And this represents all first and second doses. And we're also doing third doses as booster doses. And additionally, 6,531 boosters have been administered. On November 3rd, we began vaccinating children ages 5 to 11. And as of Monday, November 8th, a total of 108 vaccinations have been administered to this group. Whitmith administered boosters to the residents of the Masonic Home in Union City, and 407 residents were vaccinated there. Moving on to some of the health and wellness and educational events that we've had. We had on October 14th, Washington Hospital hosted our Think Pink Breast Health Awareness event on Facebook Live and YouTube. The event featured experts on breast cancer and mental wellness. We had 198 community members participated in the live event, and then another 194 additional people accessed the presentation. So it was very successful. On November 4th at 3:30, Dr. Jack Rose, our neurologist and neurointensivist and co-medical director of the stroke program, with Maria Nunes, nurse practitioner, presented stroke warning signs and prevention. They had 97 community members that participated, and then since that time, 211 additional people accessed the presentation on one of the social media channels, I should say. Then a couple of our upcoming events. We have on Thursday, November 11th at 6:30, Dr. Jet Liu, our orthopedic surgeon, will be presenting Why Does My Ankle Hurt? Causes and treatment of ankle pain. That will again be on Facebook Live and YouTube. All of these will be. On November 17th at 6:30, Deborah Chris and Heather Heath, both RCPs, will present Keeping Your Lungs Healthy. On November 18th at 7 p.m., Dr. Victoria Leapart will present Always Tired, Ways to Fight Fatigue. On November 24th, and December 1st, Christy Caracappa, our health insurance information coordinator, will present to community members at the Age Well Center in South Fremont, Medicare options for 2022. And then lastly, Dr. Sarah Wortman on December 7th will present Healing Foods, Our Food Choices and Our Health. And again, all of these will be on Facebook Live and YouTube. I do just want to thank the foundation and acknowledge that the foundation has concluded its most successful Top Hat Gala to date. They raised over $470,000 from 115 donors in support of Washington Hospital's new inpatient acute rehab center. So definitely very much thankful for all of those who participated, and I know Fremont Bank Foundation was also a generous donor for for the Top Hat Gala. Also, our Grateful Patient and Plan Giving programs. We have documented approximately 2.1 million in estate gifts from community members. And on November 30th, the foundation will raise funds through Giving Tuesday. And donations that are made will support maternal and child health at Washington Hospital and will be matched 2-to-1 up to $10,000 by our generous donors, Dr. Jean and Barbara Berry. And then lastly, the foundation will also host a tree lighting ceremony on Wednesday, December 1st from 5:30 to 6:30 p.m. by the fountain at the corner of Maury Avenue and Paseo Padre. And so this will be a community event and we'll have holiday carolers and a visit from Santa and Mrs. Claus. So those are some of the upcoming events, and very thankful to the community and everybody that supported our Top Hat Gala. And really, we're excited to be moving forward with our new inpatient acute rehab center. And those are my announcements for this evening.
Great, thank you very much, Kimberly. Hats off to the foundation for their spectacular work, and many thanks to Fremont Bank for their wonderful support. And it's great to hear that we're going to have a tree lighting in person with carolers. That's going to be good. I'm looking forward to that. Yeah, it's about time. Well past time.
Outside.
Yeah, very good. So before we go into closed session, are there any matters that the board members would like to bring to the attention of the board? If not, we will now go into closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely on the phone for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you, and the board will now adjourn to closed session.